Hey YouTube, it's Marida and welcome to another edition of the Nurse Lounge. In today's edition, we're actually going to talk about why I don't like couplet care. And I know that's such an unpopular opinion, but we're going to tackle or talk about why I don't like couplet care. If you want to know more, stay tuned. My name is Dr. Marida P. I'm a registered nurse. I've been a nurse for 16 years. OBGYN, well baby, is my specialty area. I have now moved into to academia full-time, an associate professor at a university locally. And I want to talk about couplet care. Now, for those of you who do not know, most hospitals have moved to what we call couplet care. Couplet care is when basically one nurse takes care of mom and her baby. If she has twins, sometimes the mom will take care of both twins, but a lot of times they will, if it's just twins, they will have the mom and the two babies. But if it's not, then like if it's triplets or things like that, sometimes they have to split them up with the nurse. But for the most part, it's mom and a singleton baby. And then she may have other patients as well. But typically you can have up to about 3 to 4 couplets depending on the hospital and their staffing matrix. So 3 to 4 couplets is basically 6 to 8 patients. So now let's kind of talk about what the facts are about couplet care, what they say about it as to why it's beneficial, and then I'm going to tell you why I don't like it. Okay. So again, like I said, you will have as a nurse, you will have 3 to 4 couplets, which is 6 to 8 patients, and it depends on what's going on. Keep in mind that typically why hospitals elect to do couplet care, because it keeps the mom and the baby as a one unit. And you have one nurse who knows about mom's situation as well as the baby situation. She is talking to the OB about her. She's talking to he or she is talking to the pediatrician about the baby. And basically that provides a continuity of care that is continuous and that is very much more holistic to that family and to that unit, instead of having all these separate entities, so to speak. Now, though that sounds great in theory, you know, when it comes to get a report, as an example, for mom and then get a report for the baby, you know the whole story. So if mom is on drugs or whatever, you know to expect to be watching for the withdrawal symptoms for the baby because you got that in report. Now, that is still true if we do it, you know, postpartum in a well baby nursery or the baby's in NICU. You will get report both the same way, but there may be things that maybe the nursery nurse didn't know that the postpartum nurse knew because they told that in report, but was not told in the nursery, or vice versa. So, you know, those are some examples. Or like, for instance, my mom came up positive or negative for a drug, but somehow the baby came up positive, which is questionable. So when it comes to things like that, it just helps to have that whole unit to know what's going on with mom and baby. Again, in theory, that is great. However, let's talk about the reality of couplet care. And before I go on, let me preface this by saying that majority of the hospitals that I know, besides the hospital that I just left, all does couplet care. Everybody pretty much does couplet care for the most part. Very few hospitals are still doing a set aside postpartum and a nursery. Very few hospitals are doing that separate. So from the patient's perspective, from what I was taught, that yes, it's a great thing for couplet care and that most moms like it. And most families like it because, you know, they can be with their baby 24/7 and on and on and on. However, I took some notes. Okay, I have some notes here in my book. And I want to talk about why Dr. Marida doesn't like couplet care. And you may say, well, that's being selfish or whatever. You know, it's best, whatever is best for the family. This is true. It is whatever is best for the family. However, if the nurse cannot keep up with the demands of what it requires and it makes patient safety an issue, then that is null and void at that point in time, because there are issues that we have with that can create issues for patient safety for both the mom and the baby. So one of the first things I have on here is the acuity. So I just told you the ratio is 1 nurse to 3 to 4 couplets, which is 6 to 8 patients. Okay, so you have to do 3 assessments on an assessment on mom, 3 moms, and assessments on 3 babies, or 4 and 4. However, let's keep this in mind. If you have a drug mom, you're more than likely going to have a baby withdrawing from something, right? So you not only you're caring for her, and depending on what her drug of choice is. So let's just say, for instance, she took prescription. Maybe it's not drugs in the sense of like heroin, but let's say she took prescription Lortabs as an example, okay? And they're prescribed to her so she can have them, but she took them, okay? Which is not illegal if they're prescribed. So let's make sure we understand that. However, baby, while in utero, has been getting that Lortab as well, right? But now that the baby is out, guess what? Baby's not going to be getting Lortab, but mom can continue to take Lortab. So her issue, she won't be withdrawing because she can continue to take it after the fact. They're going to encourage her to breastfeed, the mom to breastfeed, but at the same level, the baby is not going to get the same level of Lortab that the baby was getting in utero. So even with breastfeeding. So therefore, the baby's going to go through withdrawals. Who do you think deals with that withdrawal and does the NAS scoring and things like that? It's the nurse who has to do that. Now, anybody who does not know what that entails, it's a lot. It's a lot to score a baby for withdrawal, a lot of work that you have to do. And keep in mind, that's just one couplet that you have. You have 3 to 4 or 2 to 3 other couplets that you are taking care of. Now, I've had situations where with the acuity, we have high acuity moms and high acuity babies. What if I have someone, maybe it's not a drug issue, but maybe it is diabetes. So if mom has gestational diabetes, her blood sugars are up. That baby was born huge, okay, large for gestational age due to like macrosomia, due to the fact that the mom had diabetes. Then guess what the baby is going to do? The baby's blood sugars can bottom out. Why? Because the baby is no longer getting that sugar, if you will, from mom. So therefore now, since the baby's not getting that sugar, it has a hard time maintaining its blood sugars itself. So therefore their blood sugars can also be low. Again, high acuity issues warrant a lot more care. And if you have 2 or 3 of those situations going on, then guess what? It's that much harder. Now, the next thing we talk about on here, I put on here drug withdrawal, which we just talked about, staffing issues. So a lot of times you don't have enough of anything to cover anything. So therefore the staffing issues are always a big deal. So not only do you have OB and babies on your floor, majority of the OB floors have what's called GYN surgeries on the floor, gynecological surgeries, female surgeries. Well, those nurses have to take that too. So you'll have maybe 3 couplets, which is 6 patients, and then you'll have 1 GYN, which is a potentially fresh female surgery. So now that's your med surge component right there. So you're kind of like, okay, well, who is taking care of all these patients? You are. You have that GYN, and she could be someone who is 70 years old, who has dementia, who came in for a bladder prolapse or some type of female issue. You're dealing with her dementia, her surgery, her hypotension or hypertension. She may have diabetes as well. She may be at fall risk because she is older and can't see that great. She may have cardiac issues or oxygenation issues. You're dealing with that as well, okay? So keep in mind, it may not be just couplets on your floor. You may actually have GYN surgeries on your floor as well. And you may have antepartums on your floor. So antepartums are patients who have not delivered yet. She is still pregnant. Maybe she's high risk OB and she is there for pyelonephritis. So she has basically a kidney issue, okay? She's there for pyelonephritis and she needs antibiotics. So if she's there for those types of things and she needs antibiotics, she is somebody else you may have on your floor. So you may have 3 couplets and her. Or they may give you 3 couplets, which is 6 patients, that GYN and that antepartum. That is not easy, okay? Or she may have hyperemesis. Hyperemesis is basically where, they're throwing up all the time and losing weight and stuff like that. Which happens very early in pregnancy for most people. But nonetheless, you're taking care of a patient like that. So keep in mind, so those are things that you basically have to kind of keep in mind, because otherwise you're like, okay, well, I got all these patients that I care for with different disease processes. I got these couplets that need to be cared for. I got the antepartum. I have the GYN surgery, and all those things can come into play that you have to take care of all those patients. All right, the next thing I wanted to talk about was circumcision. So if you have a baby that happens to be a boy, in terms of your patient wise, you typically, unless they have like a tech or someone who goes and does those procedures, you have to go do your circumcisions with the doctor. So when the peds doctor comes in and ready to do circs, if those are your babies, you have to go do circumcisions in the circ room, unless you all have a tech or somebody who does them for you. But at the hospitals I've been at, especially if you work in a facility in which a lot of times the doctors sometimes will come in at 5 or 6 in the morning to do those circs. So if you work night shift and they come in at 5 or 6 in the morning to do them circs, then it is you who have to go over there and help do, help be the circulator basically for the circumcisions. And then if you up there with the circumcision, who taking care of the rest of your patients out there? Think about it. Nobody. Unless you happen to have a good team, but for the most part, they just as busy as you are. So nobody. So therefore, you're taking care of, you're watching that baby get circumcised, and then after that you have to do what's called recovery for that baby, and that requires you to be there and watch and change diapers and look at that incision, that circumcision, and check for bleeding, and you have to document every 15 minutes for the first, so depending on what your protocol is at your facility, for the first so many hours or whatever. And then if you do have someone who comes in at night shift to do, or the middle of the night or early in the morning to do those, you also have your end of the shift rounds that you have to do and you have to get done. So again, when it comes to some things like that, no one's taking care of your, no one's taking care of your other patients but you. So if no one's taking care of your other patients, then if they needed medications or they need whatever, you have to figure out a way to tend to that, or they're just going to be late. Okay, so that's just a reality. They're just going to be late, and I've had that happen before, where I've had my medications be late because I'm too busy doing a circumcision at that point in time. What happens when your mom or baby is sick? And I kind of alluded to this already. When you have a high risk couplet, when mama is sick, or I've had a mom who threw a PE before, a pulmonary embolism. So if she throws a pulmonary embolism, guess what I have to do? Guess how much care I have to provide for her? Do you think I have time to give great care to that baby? It's things like that they don't think about, that it works in theory, but in real life, when you have high risk patients, it doesn't work that well for. I told you about chasing blood sugars for mom or baby. If she's a diabetic, a gestational diabetic, or just a real diabetic, regular diabetic, and the baby, you're chasing blood sugars all night or all day. And that can be hard to do, because then you're giving insulin and you're giving this, and the babies get sucrose. I mean, it's just, or whatever they're getting, or formula fed actually. It's a lot. And then if the baby doesn't recover from that, then the baby gets transferred to NICU, and then there's a protocol for that. For it can't keep his blood sugars up, or can't keep his temperature up, and you have to be the one taking care of that baby until they decide, hey, we're going to go ahead and transfer the baby to NICU. So it's very difficult. The one thing I have here that most hospitals have is that when you have a rooming in situation, or a couplet care situation, that most places don't have a formal nursery, meaning that the moms are expected to keep their babies. Every place that I've been, I'm not saying it's 100%, but they don't have a formal nursery. They don't have somewhere you just send these babies off to keep, when the mom is tired. So what ends up happening is the nurse has to then babysit the baby at the nursing station, which, okay, so when can she have time to charter to make her rounds on her other patients? And again, this is not 100%. So maybe some hospitals have gotten better with that and making sure that the patients or moms are, they have a reprieve or a nursery or a place for the babies to go when mom is tired and don't want to keep her baby. But some hospitals are mandating that moms keep their babies at all times, with the exception of when assessments are being done. But that's not really fair to the patient either, And their thought process, well, you're going to keep the baby at home with you all the time, which I get that. But in a hospital setting, I've had a situation personally where the mom was withdrawing from whatever drug it happens to be. She was actively withdrawing from the drug. The baby was also going through withdrawals from the drug. Because the baby was going through withdrawals from the drug, she was frustrated when the baby cried all the time, because crying is what those babies do more. It's a certain kind of cry that they have. And she basically was about to shake the baby, and I caught her in the process of doing that. So I took the baby away from her and kept the baby with me at the nurse's station because I knew the baby was withdrawing, but yet it didn't score high enough to go to the NICU yet. And that is very, very difficult to deal with. So again, these moms need an outlet where the babies can go somewhere, and they wasn't able to do that. So sometimes not having a nursery or NICU is a hardship on the nurse, not the mom or the family. It's hard. What do you do in that situation? And then, I put in here like as the last note that nurses keep the baby. And that is very much true. The nurse keeps the baby at the nurse's station or wherever she may be sitting at. And again, that's very difficult to have to endure when you are a nurse taking care of 5 or 6 other patients. So those are a few of the reasons why I'm not a fan of couplet care. And when I first did couplet care, I was probably about a year out of school. So I did it for maybe a month, and I quit that job because I hated it so bad. But then I attribute it to maybe me being fresh out of school, not knowing how to properly do this and knowing my role as a nurse. So I attempted it again, probably in 2016. I think 2016, I think I attempted it again, and I did it for a year and a half. And so in those 18 months, I realized I still don't like couplet care for the exact same reasons that I just told you I don't like couplet care. And I'm kind of like, this right here is not for me. So I ended up quitting that hospital yet again. That's a different hospital, but quitting couplet care yet again. And honestly, for the most part, unless it's a small hospital that only can guarantee me 2 to 3 couplets, I don't see me ever going back to couplet care again. And I may say that and do a travel assignment and have couplets, okay? But actually I'm getting paid to deal with that, So we will see. I don't like it, but of course that's where we are trending or headed towards in terms of healthcare when it comes to OB patients is couplet care. So I don't want to say I will never do it again, but it's something that I will never say, oh, well, me next, I want to do couplet care. So that's my 2 cents. I really don't care for couplet care, but I do see where they say it can be beneficial in theory. Thank you so much for watching this video. If you want to see more videos like this, then please thumbs this video up. Definitely comment, like, share, and subscribe. It is free to subscribe to this channel. I have a plethora of nursing videos, and I also have a plethora of other things that's going on in my life. And I just started a new series called Mother-Daughter Talks, where me and my oldest daughter actually talk about and tackle issues with Black women, issues with single parenting, issues with education for Black people. We talk about it all. If you want to hear our perspective on that, definitely go see those videos and subscribe. You can follow me on IG, and the handle will be somewhere on the screen. And definitely go follow me over there. You can email me as well with your questions or concerns. And until the next time, you all take care. Bye-bye.